This video and the ones that follow will review a comprehensive approach to shoulder arthritis and our shoulder replacement program. The idea behind these videos is to provide comprehensive patient education and preparation for people who are considering or scheduled to undergo shoulder replacement surgery. By reviewing these videos, you should have a full picture of what the process of shoulder replacement is all about. We thank you for entrusting your care to us for your shoulder replacement. As a practice that specializes in joint replacement surgery, we have built a comprehensive program called Avatar that is designed to facilitate the recovery process and improve outcomes. Our team of physicians, physician assistants, nurse practitioners, and office staff are all highly dedicated to the Avatar process and to our patient's end result. This manual is your guide to the Avatar shoulder replacement program and is meant to help you prepare for surgery and maximize your recovery. If you have any questions that require further information, please contact us at any time at 603-431-5858 or at avatar@kneehipshow.com. Here's a little information about me. I'm a fellowship-trained shoulder surgeon with a subspecialty interest in shoulder replacement. I am a member of the American Shoulder and Elbow Surgeons, a founding member of the New England Shoulder and Elbow Surgeons, and a specialist in outpatient joint replacement surgery. We'll now talk a little bit about shoulder anatomy. The shoulder is a ball and socket joint. The ball sits on top of the arm or humerus bone, and the socket is part of the shoulder blade, also known as the scapula. Cartilage covers these surfaces to provide a smooth gliding surface. In addition, there are key tendons and ligaments that move and stabilize the shoulder during everyday function. This is a glossary of common terms used in shoulder anatomy and shoulder replacement. The glenoid is the official name for the shoulder socket. The humeral head corresponds to the ball of the ball and socket joint. The labrum is a ring of fibrocartilage tissue that surrounds the glenoid. The capsule is a connective tissue layer that surrounds the joint and is reinforced by ligaments. The rotator cuff is a group of 4 tendons that surround the humeral head or ball and provide motion and stability to the shoulder joint. The rotator cuff is comprised of 4 tendons: the supraspinatus, subscapularis, teres minor, and infraspinatus. The deltoid forms a cuff over the top of the rotator cuff. The rotator cuff acts to stabilize the humeral head in the glenoid concavity and to power internal and external rotation of the arm. The deltoid is the prime mover in elevation of the arm. Optimal deltoid function relies on a functioning rotator cuff to keep the head centered in the socket during arm elevation. Shoulder arthritis occurs when the cartilage that forms the smooth gliding surface of the joint wears away, exposing the underlying bone. Other adaptive changes occur as a result of this. These include osteophytes or bone spurs around the ball and socket, flattening of the humeral head or ball, bone cysts, and wear and erosion on the socket side. Shoulder arthritis can result in different patterns of glenoid or socket-sided wear and erosion. The pattern and the severity of this wear process may dictate which type of shoulder replacement is best and which implants will best restore anatomy towards normal. The picture below shows the Volch classification for common patterns of glenoid erosion in shoulder arthritis. One of the more common patterns that we see, particularly in younger males, is called a B2 glenoid. This pattern of wear includes retroversion, posterior decentering, and what is called biconcavity. Retroversion refers to an increased angle between the face of the glenoid and the body of the scapula that results from the wear process. Effectively, this tilts the glenoid in a posterior direction relative to its native orientation. Posterior decentering, also known as subluxation, occurs when the humeral head rests on the back of the glenoid rather than in the center of the glenoid, as shown in the picture above. And biconcavity results when the decentering causes the posterior or backside of the glenoid to wear eccentrically, carving a second concavity relative to the native socket, also shown in the picture above. The pictures on this slide show X-ray examples of shoulder arthritis. And these X-rays show all of the hallmarks, including bone-on-bone, bone spurs, socket erosion, including retroversion, posterior decentering, and biconcavity. The following is a general guideline for when shoulder replacement is appropriate. The level of pain is moderate to severe and significantly impairs your activity level. You find yourself avoiding certain activities that you would otherwise do because of pain. You have maximized conservative measures like medications, injections, exercise therapy, etc., and your quality of life is sufficiently impaired to warrant the surgery and recovery. Now we'll talk a little bit about the types of shoulder replacement. Anatomic shoulder replacement replaces both the ball and socket in the same orientation as a normal shoulder. The ball is generally made of cobalt chrome, a highly polished and smooth metal. The socket is generally made of polyethylene, which is a very durable and wear-resistant plastic material, as shown in these pictures below. In a reverse shoulder replacement, the orientation of the ball and socket are reversed. The artificial ball is attached to the normal shoulder socket, and the artificial socket is attached where the normal humeral head is. What determines the kind of shoulder replacement that an individual needs? Currently, 70% of shoulder replacements worldwide are reverse shoulder replacements. And this is because reverse shoulder replacement has a wider list of indications compared to anatomic shoulder replacement. If you have osteoarthritis with a normal rotator cuff, no history of prior rotator cuff or instability surgery, mild to moderate glenoid wear, an anatomic shoulder replacement is likely the best option for you. In cases of osteoarthritis with severe glenoid wear, reverse shoulder replacement has been shown to have better results and fewer complications. Indications for a reverse shoulder replacement include a rotator cuff tear with arthritis, an irreparable rotator cuff tear, osteoarthritis with severe glenoid wear, patients over 75 to 80 in whom the risk of a rotator cuff tear is high, proximal humerus fractures, fractures that have failed to heal in the appropriate orientation, chronic shoulder dislocations, a failed prior anatomic shoulder replacement, tumor reconstruction, and inflammatory arthritis such as rheumatoid arthritis. Is there any difference in outcome between these two types of shoulder replacement? For patients with osteoarthritis and an intact rotator cuff who may be a candidate for either type of replacement, there are pros and cons to the reverse as compared to the anatomic. The pros in this scenario of a reverse shoulder replacement would include less risk of failure due to eventual rotator cuff disease, and potentially greater durability of the glenoid implant fixation over the long term. The cons of a reverse shoulder replacement include less overall range of motion, especially reaching behind the back, more potential for some persistent postoperative discomfort around the deltoid muscle, and particular complications such as scapular spine fractures and dislocations, which we will review in a later module. Recovery from shoulder replacement relies mainly on healing of the soft tissues. The shoulder joint is completely surrounded by the rotator cuff. In order to gain access to the joint to implant the prosthesis, the subscapularis muscle and tendon must be released and then reattached at the end of the case. Recovery from both anatomic and reverse shoulder replacement is based largely on the healing of this tendon. It takes 3 months for this tendon to be solidly healed where there is little risk of rupture. Deciding on the best humeral implant. Different implants each have their pros and cons that must be individualized to the anatomy, bone quality, and clinical scenario. As you can see in these pictures below, there are standard length stemmed humeral implants, short stemmed implants, and stemless implants. Dr. Parsons will choose the implant that balances the pros and cons to provide the best long-term outcome with the lowest risk of complications. The main goal of shoulder replacement is pain relief, and 90+% of patients will achieve good to excellent results when it comes to this measure. Some persistent discomfort with more strenuous activities may be present for 10 to 20% of patients. The keys to good outcomes are as follows: proper healing of the tendons around the shoulder, and dedication to the therapy program to regain strength and function. Arthritic shoulders are generally very stiff in all planes of motion, and replacement surgery can greatly improve this provided a successful recovery. Post-operative range of motion achieved can be affected by other issues such as ineffective physical therapy, a genetic predisposition to form scar tissue, prior surgery, significant preoperative stiffness, and other complications. In terms of return of function, while most restrictions are lifted after 3 months, patients will continue to improve for up to 2 years after surgery with continued maintenance exercises. We allow patients to return to all manner of sports and leisure time activities, but recommend against repetitive, strenuous impact such as chopping with an axe. Ability to return to specific activity is contingent on successful rehabilitation and recovery. Thank you for entrusting your care to our practice. We are committed to ensure the best possible outcomes for our patients. Our Avatar program has been refined over the years of experience with 3 main goals: less pain, better function, and faster recovery. For any specific questions, please reach out to us at avatar@kneehipshow.com.